Shom, let's just give them a couple more minutes. They just finished oncology conference.
Sounds good. Should I get started here, Ashley? Or...
I think we can. There may be some people they're going to join. I'm pretty sure they're going to join in. Everyone may know Dr. Kundu, but Dr. Kundu is the professor of urology here at Northwestern Feinberg, and he's also the chief of urologic oncology. He's done research and published in many areas across the spectrum of genitourinary malignancy, but has had a particular interest in inflammatory bowel disease and its impact on malignancy. And really, thank you for sharing this today with us, Shom, and we look forward to the talk.
Great. Thank you for everyone for joining. I wanted to share with you a couple of things that I've been working on over the course of the last couple of years, and some of this may be preclinical and a bit dry, but I wanted to really kind of share with you what I've kind of stumbled across a couple of years ago after kind of coming across a few patients with IBD and assessing their risk of prostate cancer. Really, not much data existed, and I'll tell you why I did. Oops. So, this is a patient that I saw in the clinic, and this was the first patient I saw of many, who essentially presented to me way back in, I think it was 2015, when he presented with an elevation in his PSA close to around 8. And this gentleman had Crohn's disease for a long time, relapsing, remitting, occasional flares and whatnot. And you can see over the course of probably the 4 years prior to, his PSA had been certainly sub 4. I took a little spike up, came back down, and then started going up into the 5, 6, 7. And I think we saw him at a rate PSA of 9. And reality is the people who had seen him really thought that his PSA elevation was likely due to his Crohn's disease and likely not related to prostate cancer. There's this little downtrend you see here in the PSA once he had a flare treated, but then it went right back up within a short period of time to above 5. So that really prompted me to ask the question, and I think actually polled a lot of the members of our group, what's going on? And in fact, I asked a lot of the GI doctors, is there any association between elevations in PSA and gut inflammation? And most people said, yes, probably, and that's what they thought, but really there was zero data to actually say that gut inflammation and this chronic inflammatory condition that this man and many other men have was associated with elevations in PSA. There really was really no data qualifying whether this is just a false elevation in PSA, whether it was true, and that was what prompted me to start studying this. And that's where this talk comes from. So what I want to do today is outline the potential mechanisms of how, and I'll give you a spoiler alert. I think the answer is yes, there is an association, and I want to essentially outline to you the potential mechanisms of how chronic gut inflammation in men modulates the risk of prostate cancer. Share with you what I think there may be some shared genetics between these two disease states, IBD and prostate cancer, and how a lot of these men, actually patients, but certainly men who take these chronic medications, specifically TNF-alpha inhibitors, how mitigation of this chronic inflammation, the systemic inflammation, can modulate that man's cancer risk. And that's newer data, but I thought I wanted to share some of it with you. So what is inflammatory bowel disease? It's a chronic inflammatory condition affecting the gut. It affects, patients are usually diagnosed between the ages of 15 and 35, so they're generally young. And so by the time if a man has inflammatory bowel disease, he's likely, when he approaches PSA screening or prostate screening age, decades, if not 3 to 4 decades worth of this chronic inflammation, prior to presenting with prostate cancer screening age. It affects about 1 million men in the United States and many more million in the worldwide. And the disease severity is variable. Some patients have very severe disease, some have milder disease, but it's almost invariable that patients will have some flare-ups, if not once a year, if not a couple of times a year, but certainly inflammation and flares tend to be more common than not. And many of these patients with more severe disease are managed with TNF-alpha blockade, which I'll talk about at the end of this talk. So there are two major types of inflammatory bowel disease, ulcerative colitis and Crohn's. I'm sure many of you have heard of what these are, but there are distinctions. While it is grouped into inflammatory bowel disease, there are distinctions between what they are in terms of where it happens and histologically what areas are inflamed. Ulcerative colitis is generally limited. It starts in the rectum and it works up towards the small intestines, but does not involve the small intestines. It's limited to the colon and rectum and tends not to have skip lesions. It also tends to be a mucosa and submucosal inflammation. It's not transmural. Crohn's disease may involve anywhere, any part of the GI tract, specifically lower GI tract, and it is a frequent transmural inflammatory process. So there is data that has shown there's an increased risk of gastrointestinal malignancy in patients with inflammatory bowel disease. There is some data specifically as relates to lymphoma that inflammatory bowel disease patients are at an increased risk. And the key drivers of these malignancies are thought to be from long-standing inflammation, specifically in the gut, as relates to gut-related malignancies, colon, liver, stomach, esophageal. But there may be a driving force behind immunosuppression and their cancer risk. And so this shows this graphically. This is data that was published last year in Digestion, saying that there is two schools of thoughts: one, inflammatory-related malignancies and how immunosuppression can affect malignancies. And kind of I've tried to tackle those questions within the scope of the work that we've done. So how do patients with IBD get colonoscopies, I believe, annually, because they're at a much higher risk of developing colon cancer. And these are different from sporadic colon cancers. Chronic inflammation leads to increase in reactive oxygen species, inflammation, ultimately DNA damage. upregulation in certain inflammatory pathways, such as the TNF-alpha pathway, STAT3, NF-kappa B, and ultimately the sequential acquiring of DNA damage and ultimately DNA damage to certain regulatory cell cycle regulators then causes progression of these cancers in IBD in a much faster rate than a sporadic colon cancer. Oops. So the question is there an association between these men with chronic inflammation of the prostate, their PSA specifically, and prostate cancer? So the first question I thought was, my hypothesis was that it truly was just gut inflammation, and somehow this gut inflammation is being transmitted to the prostate, and that there was no increased risk of prostate cancer, although the few patients I had seen anecdotally at the time, both were diagnosed with prostate cancer. I thought it was just purely an anecdotal process. And then, is there an association between this gut inflammation and prostate cancer risk? So first, how does it affect the prostate? Does it affect the PSA? And like I say, the patients that I'd seen elevated PSA, both of them were assumed to have gut inflammation, leading to an elevation in PSA. I asked everybody in the department, everybody in the GI department, nobody knew the answer and said, yes, it probably is gut inflammation, but we didn't really know why. So the first thing we did is we actually looked at our own institutional data set or system-wide data set over the course of about 20 years. And we identified 1,000 men who had IBD, and they were followed within our NM system with serial PSAs. And we matched that to 9,000 controls who also had the similar amount of PSA screening, and followed these men over time within our NM data set. And what you can see is these are, I think, about 33,000 PSA values plotted in these 10,000 men over the course of their life here at NM. And as what you can see here is, while it's small, it is a significant increase or divergence of the PSA. The green line represents men with IBD, and the purple line represents non-IBD patients. There's a divergence of this PSA at the age of 55, and that's interestingly when we start screening, but there were men screened prior, because a lot of these patients were probably screened before the USPSTF recommendations came out several years ago. But you can see a divergence in their PSA, and while it's small, it is significant and statistically significant. And I wanted to just share with you, this may not look like a big difference, but this is data from several years ago looking at the PSA level in Black men compared to non-Black men. And you can see this is longer, and it goes out to the age of 70 and beyond, and we didn't have that data. But if you look at this portion of the curve, it actually looks quite similar. And I don't think it's really all that controversial that Black men are at a higher risk of prostate cancer and more aggressive prostate cancer, but you can almost, not quite, overlay these PSA curves when you look at the age ranges of 55 and 70, which I thought was interesting. So that was interesting in the sense that, all right, the PSA level diverges, but what's the rate of prostate cancer? So what we showed, interestingly enough, is when you took into account age, race, the number of PSA screening exams, hospital encounters with the NM system, that the rates of overall prostate cancer were different. There was actually about a 4-fold increased risk in men who had inflammatory bowel disease compared to non-IBD patients in being diagnosed with prostate cancer. And so the next question, well, what if it's all just low-grade prostate cancer? And so the right side here represents the clinically significant prostate cancer, which we defined as grade group 2 or higher. And indeed, even within that cohort, there was about a 4-fold increased risk of being diagnosed with a grade group 2 or higher prostate cancer in men with IBD. Further, when we stratified by age at the initial PSA, so men in their 40s, 50s, 60s, and 70s compared to non-IBD patients had a significantly increased risk of being diagnosed with prostate cancer, which did increase as a function of the decade of life in which they were detected. And then finally, looking at their initial PSA and what that did in terms of portending a future risk of prostate cancer, you can see an uptrend in both but certainly the trend in men with inflammatory bowel disease was much more striking in terms of their risk of being diagnosed with prostate cancer based upon their initial PSA. So that was our own system-wide data. And the nice thing about using system-wide data is that you actually have data that's annotated. We can actually look at individual patient data, the number of PSAs, what their PSA was, the Gleason grade, staging. But the downside is it's obviously single system based. So we then looked to validate our data within the United Kingdom Biobank, which is a prospective population-based registry in United Kingdom, which encompasses England, Wales, and Scotland. And there's over 500,000 patients, of whom at the time there were over 200,000 men whose information is recorded and tracked by the National Health Service. So we knew who had IBD and we knew who was eventually diagnosed with prostate cancer. What I don't have, and I hope to get at some point, is their prostate cancer staging and grading information. And what we found is this Kaplan-Meier represents the freedom from being diagnosed with prostate cancer, and the top line represents patients' controls versus inflammatory bowel disease. And what we saw that there truly was an increased risk of being diagnosed with prostate cancer within this UK Biobank in a prostate cancer diagnosis. Interestingly enough, in the UK, PSA screening is not widely practiced. There is opportunistic screening. And I think in the overall cohort I think there was estimates of about 30% who were screened for PSA. So some of these may be actually clinically detected prostate cancers. So I can't tell you exactly how many were screen detected or clinically detected, but I suspect some of these were clinically relevant and clinically detective or for-cause diagnoses. Now, the data was not as robust as in our own institutional data set, and this is a busy slide, but overall there was about a 33% increased risk if you had inflammatory bowel disease that within this UK Biobank that a man was diagnosed with prostate cancer. And within this data, the ulcerative colitis patients actually were mainly responsible for this increased risk. We did not find that with Crohn's disease. So a little different from our data, but did validate that there was an increased risk within a large population-based 200,000 patient cohort. So why is this happening? So is this local inflammation? So bacteria or local inflammatory signals which are being transmurally going into the prostate? Is it systemic inflammation such that cytokines or bacteria are going into the bloodstream and ending up in the prostate? Is it immunosuppression that many of these patients take? Or is it a genetic predisposition? So the next part of this talk is just saying how we looked at some men with prostate cancer, their biopsy slides, and we did a mouse model to actually study it. So we actually looked at a group of men. It's hard to get tissue from patients that are not prospectively collected, at least at the time it was, to get tissue and compare it to controls. But what we found here is the top row represents controls, the bottom left represents IBD patients. And there was a higher level of staining of both T and B lymphocytes within men who had prostate cancer, including CD4 and CD8 T lymphocytes within the tissue. Now, this was a small group, but it really led us to the next step, is to try to develop a preclinical model to see what's going on within the prostate. So what we did is we took mice. There are several well-established IBD mouse models, and one of them is a chemically induced IBD mouse model. You give these mice something called dextran sodium sulfate. It's a complex polysaccharide. Essentially disrupts the mucosa of the gut epithelium, mainly of the colon, and it causes direct epithelial cell damage, and it mimics, it's a well-established model for IBD in the mouse. And so what we did is we gave them at the age of 9 weeks, a week of DSS, then they get 2 weeks of rest. And then we repeated that twice. And the blue line represents the weight of the mice, and the red line represents the DSS treated mice. And as expected, and you would expect once they get DSS, They drop their weight, you give them a break, they recover, they drop it, they recover, and then they drop it again. So this is in line with what we would expect. And it does mimic a chronic inflammatory bowel disease condition model. So we did find that there was indeed the increased lymphocyte, or really inflammatory infiltrate within the colons of the mice, which we expected. The question is now what's happening in the prostate? So number one, we wanted to make sure that this DSS wasn't directly somehow being filtered by the gut and going into the kidney. And the top represents mouse colon, and this purple on the right represents DSS treated. Hopefully you guys can see that. And you can see this toluidine staining of the mice, in the colon of the mice. But in the bottom, you can see that the mouse prostate, in neither case actually did we see any of these toluidine staining, suggesting that any signal that we were potentially seeing was not just a direct effect of DSS going into the prostates of these mice. So what we found is, number one, now this is all in prostate tissue, that in mice that there was a higher level of overall leukocytes and specifically CD8 cells. Now it's a little bit different than the human counterpart, but this was really exploratory. That if mice had colitis, there was a higher level of leukocyte infiltration, specifically CD8 cells within this cohort. And then we looked at a few more mice and found that, again, the CD45 is a general leukocyte antigen marker, that when you gave these mice colitis, there was a significantly increased amount of CD45, CD8, and B220 cells, which are B cells within the mice of these prostates, suggesting that there may be something associated with gut associated inflammation that's being transmitted to the prostate. This was not a transmural process. That means we didn't see all this inflammation going through the mucosa of the colon into the prostates. The intervening tissue was not affected, that truly this may be some kind of inflammatory or bacterial or process that's being transmitted. We looked at inflammatory cytokines. So this was a panel of inflammatory cytokines, and we expected to see certain cytokines like TNF alpha actually increase, and it wasn't. It was actually decreased. IL-6, which some of the work that one of our colleagues, Dr. Jennifer Wu, has done, has shown that's an increased risk, her IL-6 mouse model shows that it may be associated with increased risk of prostate cancer via inflammation. But there were a whole slew of cytokines that were increased within the prostates of the mice that had colitis. And we're going to focus on the last three here because they were the most highly expressed. And I'm not going to belabor this point, but essentially there were three things that were most highly expressed. These were something called TIMP, CCL5, and CXCL1. And what TIMP is, it's an extracellular matrix remodeling protein. High levels of TIMP are associated with progression in certain types of cancers. CCL5 is a chemotactic cytokine for immune cells, and CXCL1 is also a chemokine which is involved in neutrophil recruitment and trafficking. And what we found is that in the bottom here, that you can see that there were higher levels of TIMP, CCL5, and CXCL1 as demonstrated by this staining in the mouse. So is there other data suggesting that these agents that I just spoke about, these cytokines that I just talked about, is associated with either cancer progression or development? And the answer is yes. TIMP1 has been well established in colon, which is associated through essentially through AKT phosphorylation of the PI3 kinase pathway, as associated with a progression and metastasis within colon cancer. It's also been shown in pancreatic cancer, and it's also been shown on CXCL1 in pancreatic cancer and CCL5 in lung cancer. There actually is data within prostate cancer. If there's prostates that have higher levels of TIMP1, again, which is an extracellular matrix remodeling cytokine, that it has a higher level of progression, cancer progression within these patients with prostate cancer. And there is data as well with CXCL1 and CCL5 in progression of prostate cancer. So there is data actually supporting that independently of how the gut inflammation is associated with it. And these are Western blots essentially looking at some of the downstream regulators that are associated with upregulation of these genes, specifically, or cytokines, specifically NF-kappa B phosphorylation, which you see is significantly increased within the colitis mice. AKT phosphorylation is also significantly increased in mice with colitis, which you're seeing here. And then we did look at MYC because a lot of these AKT phosphorylation, with some of the work that we were doing with Sarki, Abdul Qadir, in his c-MYC mouse models, we looked at MYC and there was an increase in MYC expression within the mice prostates of that had colitis. Oxidative stress. So in colon cancer, inflammation induces oxidative stress. And we used this marker called gamma H2AX and did show that there was an increase in oxidative stress leading to DNA damage. The red represents the amount of staining for this DNA damage marker, and it was higher in the prostates in mice with colitis. And then also another marker of reactive oxygen species and how that potentially can cause DNA damage, this 4-HNE. You can see on the bottom here, there's much more intense staining of this 4-HNE stain in mice with colitis than in control mice. So this is the hypothesis. There's a lot of work that needs to be done with this, but that the murine prostates, or these mouse prostates, or the mouse gut, when it's inflamed, demonstrates increased levels of immune cells and pro-inflammatory cytokines like TIMP1, CXCL1, and CCL5, which ultimately can alter the local environment and potentially make this more tumor permissive than in a non-inflamed prostate. This may cause downstream dysregulation or upregulation of the AKT phosphorylation, NF-kappa B, and the MYC pathways, which can be associated with an increased risk of prostate cancer. And ultimately, DNA damage, reactive oxygen species may lead to cellular senescence and essentially be permissive of cancer cell growth and maintenance as opposed to cell death. So I think one of the main questions that we are in the process of studying or looking at is the microbiome. So, the microbiome for me is a little bit hard to grasp completely. I think it's hard for many people to grasp, but there's many different microbiomes. There's a urinary microbiome, a skin microbiome, obviously a gut microbiome. But one of the things we started to do is look at human prostate tissue. And we actually did this work with Gene Chang at the University of Chicago, where he stained these human tissue in controls versus men with IBD, and found that there was a higher level of 16S ribosomal RNA expression within the prostates in men with IBD. Now, unfortunately, what we don't have is what type of bacteria is this. We don't know if it's a urinary bacteria or a gut bacteria. And so what we're trying to do is establish a mouse model. And he has a nice IL-10 mouse model that when you get these IL-10 knockout mouse, when they get exposed to certain bacteria, which their previous mouse room had, they invariably got IBD. Unfortunately, recently they changed their mouse room and it's too clean. And so while we're trying to give them IBD, the mouse room is too clean and they're not getting IBD. So we're rethinking that and seeing what we can do. But we're trying to establish to see what is the effect of the microbiome, and specifically what we want to try and do is give them a controlled ingestion of certain bacteria and see if these bacteria within the gut are making it into the prostate, suggesting that truly there may be an effect or in IBD and inflammation of the gut that's making it into the prostate. So it's a little preliminary, so I hope more to come on that. Next, I'm going to move on to the shared genetics. So, one of the questions, and we know that IBD, there are many SNPs that are single nucleotide polymorphisms that are associated with an increased risk of both prostate cancer, and similarly the same with IBD. So what we did is work with John Whitty at UCSF, who has now just transitioned to Stanford, where we first looked at genome-wide association studies and 2 large genome-wide association study cohorts, including practical within the prostate cancer data set and DeLang, which is a huge GWAS cohort for IBD. And we found that there were many genes that were, SNPs, I should say, that were increased in both. But one of the challenges I found with the GWAS studies is, while we find SNPs, we don't actually know the functional impact. So what we chose to do next, and more recently, is looking at transcriptome analyses in patients with IBD and prostate cancer. So to do this, we used a certain program called the Metascan to test for the association between imputed gene expression within the tissue of patients with prostate cancer and IBD, and then subtype them as well. Now, this is a global tissue data set, imputed tissue data set. So, we will start looking at specifically gut and prostate, but this was all tissues, and looked at overlapping genes that had essentially the same direction, i.e. they were both increased or decreased. And what we found within the tissue-wide association is there was a handful of genes, which are here in the red, that were associated in the same direction, that were co-expressed, or meaning they were associated, they had increased expression in both IBD and prostate cancer. The red are significant. What I'd like to point out is this one gene that I'm very interested in, this TNFR SF6B. Essentially, it's a TNF alpha superfamily gene, which is associated with an increased risk of cancer progression in many cancers. So it just, in the overall IBD and prostate cancer, this TNF super gene came up. And then we looked at individual Crohn's disease and ulcerative colitis, and they had differences, but what was most striking is this TNF alpha super gene was the most strongly upregulated or expressed in both cohorts. So these are the genes. These are the genes that were most highly expressed in both. And I have a lot of work to do as to figure out what this interaction is. But again, what is this TNF6 gene? It's a TNF alpha superfamily member. And what's interesting is it's actually serves as a decoy receptor. So in certain cancers, what happens is this serves as a decoy receptor, which actually reduces the risk of some of the TNF alpha mediated death of some of the cancer cells. We did gene enrichment analysis just to say, are there certain gene sets or gene sets which are co-expressed or co-upregulated? And a lot of it, and the answer is yes. A lot of these are immune regulatory gene sets, which absolutely makes sense from an IBD standpoint, but there seems to be some commingling within the prostate cancer cohort as well. And this last little thing looked at, we asked the computer to say which genes are upregulated and are the disease sets that are expressed in both. And then you can see here on the right side here, for example, IBD and IBD, the dot is large. It's the biggest dot you can get. We didn't actually query IBD, rather the computer, even though it's a small dot, it's a significant finding that within the gene sets that are upregulated, inflammatory bowel disease and prostate cancer, while it's a small group of gene sets, there were a statistically significant number of gene sets that were co-upregulated in both inflammatory bowel disease and prostate cancer. So this is
Shom, can I ask you, Shom?
Yes.
Ted, I have a quick question for you. You alluded to this immune modulatory networks that were altered. The patients who you profile, were they on or not on any immunosuppressants for their IBD, or what's the story behind their medication use?
Yeah, these are large cohorts of practical and DeLang, which we don't have that annotated data. So these are all GWAS-based studies.
I see.
I don't have individual annotated data. So I don't have, for example, how long they were taking TNFs, if they were. So that's one of the challenges with some of this data is you can get population-based or genome-based data, but it's hard to get individual patient data. So this is work that was done by Adam Wiener. What we looked at is, and this is work with Dr. Schaefer and Tamara Lotan from Hopkins. We looked at this specific gene. Now this figure is a little bit misleading in the sense that these were not IBD patients, but rather there was a cohort of about 500 men who underwent radical prostatectomy, who had tissue expression done. And what we isolated is this particular gene, actually the whole set of genes that I just showed you previously. And this came out as probably the most significant gene within the cohort, within the set that I just showed you, this TNF alpha super gene, which essentially is associated with TNF alpha dysregulation in cancer. And if you had high levels of this TNF super gene expression in prostate cancer patients, that it was associated with a higher risk of prostate cancer metastasis, taking into account and adjusting for PSA, grade group, margin status, and Decipher. So I think it's just hypothesis generating. The fact that I think the TNF story could be playing a role within this whole inflammatory cascade.
I will say one thing, Shom, about the data set.
Yes.
And that is that entire data set was collated and organized by Ashley Ross. So although it's always referred to as the Lotan set now, because she's the only one remaining at Hopkins, actually Ashley did all that work.
Well, Ashley, thank you. This figure, then, I need a shout out to Ashley Ross here. Then.
I'm happy to see it going to good use.
So the last question I wanted to answer as I wrap up here is, what happens with TNF agents? So I'll tell you, with patients taking TNF alpha medications. So what is the effect of TNF alpha? Because we always think of it as an immunosuppressive agent. So we know that there's an increased risk of lymphoma. But if you actually give TNF agents to IBD patients, for example, you significantly reduce their risk of colon cancer. And so these patients can almost have a colon cancer risk that's as close to the general population if they're on a TNF alpha agent, if you really aggregate some of these inflammatory signals. But the long-term effects of long-term data on how TNF alpha agents affect cancer risk is terrible, mainly because most of the studies, including the meta-analyses, and we're about to publish ours soon, are really pretty poor because they look at 1-2 year data and they're looking at really efficacy of the medication, and they're not looking at long-term cancer diagnoses. So we hope to have data for you soon on that. But we wanted to look at and what does TNF do? So we know in high levels of TNF, it can induce endothelial cell death, tumor necrosis, and tumor regression. But actually, with low levels of TNF and chronic TNF, there actually can be a tumor permissive environment because it can actually cause death of CD8 tumor infiltrating lymphocytes. It actually can increase PD-L1 expression on cancer cells. And then chronic low levels of production of TNF can actually can affect immunosuppressive T cells, such as T regulatory cells, and actually cause tumor progression. So TNF, the story of TNF is not straightforward, at least not to me, but I wanted to see what happened within our cohort. So TNF, as I said, can induce cell death, but actually in low levels, it can serve as a tumor promoter by promoting myeloid cells, angiogenesis, killing CD8 cells, and increased PD-L1 expression on tumor cells. So what about the TNF alpha blockade on prostate cancer risk? We actually looked at all cancers, but for the purposes of this talk, I'm just going to focus on prostate cancer. What we did is looked at our NM system-wide inquiry. And again, as you said, Ted, we really don't know when these population-based data, who was taking a TNF, how long, why, for what reason. So that was one of the strengths of our own NM system data set, where we looked at 10,000 patients who were exposed to a TNF agent, including patients with inflammatory bowel disease, but we actually also included psoriasis, ankylosing spondylitis, psoriasis is there twice, and rheumatoid arthritis. And we had 10,000 patients, and we matched those. Actually, we didn't match. We actually took every patient in our system with those particular conditions, and there were 38,000 patients. And we found that 10,000 of them were exposed to TNF-alpha inhibitor, and 28,000, at least within our own prescription data, did not have any exposure to a TNF-alpha agent. And I wanted to see what the risk of cancer was. So interestingly, what we found is we did propensity weighting because there were some differences, but when we accounted for and adjusted for age, PSA, number of screening exams, number of visits, and smoking status and other things like that, that there was a significantly protective effect against the diagnosis of prostate cancer in this cohort. I just included some of the other cancers, which I'm interested in looking at. There seemed to be a slightly protective effect on kidney cancer and bladder cancer. And we're working on teasing out the individual data. It does not seem that there were differences in specific Gleason grade, at least preliminarily. But this effect, we tried to figure out factors that were maybe associated with bias, and you never can really get away with reducing all bias within this cohort or retrospective cohort, but it seemed to be pretty strongly protective. What about the disease state for which they were used? As expected, and as we would hope to see based upon other data, with ulcerative colitis and Crohn's, this is a relative risk of 1. It seemed to be protective. I don't know how to explain the psoriasis because this is something we looked at, but certainly something we're going to go look to in the future. Psoriasis patients seem to have the highest, the greatest protective effect, and I've included it here, but I can't tell you much about it. But it does show within the inflamed gut cohort that there was a protective effect. And actually in the overall cohort, a lot of these inflammatory driven cancers, i.e. colon cancer, liver cancer, stomach cancer, it showed that it was protective, which is what we expect from known data. So I think there may be something to this that I hope to be able to elucidate in the future. So with that, I'm going to conclude, and I want to just make some concluding remarks here. I believe there is an association with IBD and prostate cancer, and in our cohorts and some of our population-based data, IBD is associated with an increased risk of a prostate cancer diagnosis in a man's lifetime. So I would say, for those of you seeing IBD patients, don't just assume it's from gut inflammation only. In preclinical models, gut inflammation is associated with a pro-oncogenic milieu in the prostate, not just in the gut. And there may be a shared genetic profile in these men with IBD and prostate cancer, which we hope to kind of tease out over time. This TNF-alpha superfamily gene, which I think is very interesting and seemed to be kind of the standout in terms of this entire TWAS-based evaluation, is something that I think is very interesting. And I think the use of TNF-alpha inhibitors, interesting, was protective against the diagnosis of prostate cancer, but the mechanisms are yet unclear, and we hope we'll be able to tease that out. So with that, I wanted to thank all the members of Dr. Abdul Qadir's lab, and Anuj and Vinay, who really helped kind of move this forward. I wanted to thank Connor Driscoll, who is one of our PGY1 residents, who's moved a lot of the TNF stuff forward, and I think there'll be a lot of data coming out, not only in prostate cancer, but some of the other data sets that we have. And the UCSF team, which has helped to navigate some of the genetics-based work and hopefully help us figure out what the shared genetic basis of this phenomenon may be. So thanks everyone for your attention, and I'm happy to entertain any questions. Thank you.
Thanks so much, Shilajit. So if a person has IBD and their disease is not severe enough that they need to be on TNF-alpha, like particularly with ulcerative colitis. A couple questions. One is, so should we inform inform internists or the patients that, look, you need prostate cancer screening, and what age should that begin? Like at 40? And then the second follow-up is, you wouldn't ever recommend TNF blockade for them in any way, right?
I think that's those are really interesting questions. I think I'm really interested by the TNF alpha story because I think that seems to be kind of where things are converging based upon at least some of the genetic-based work and some of the clinical work. So I'm going to go back. So, where the PSAs tend to diverge is starting at the age of 55 or so. Sorry, let me get to it here. So, right at the age of 55, you start to see a significant difference between the two. So I think the whole point is, in all of this is, number one, if you have patients with IBD, maybe they will serve as a higher risk cohort that should be considered for screening, or maybe considered higher risk that we need to evaluate our screening-based practices. I think internists and GI doctors, but probably the internists, should be educated that elevations in PSA shouldn't be just treated as IBD flares or gut inflammation and presumed to be nothing, which is what I've seen a handful of times, more than a handful of times. And that this group maybe truly represents a group that we need to study and recognize as a high-risk cohort. Now, in terms of TNF use, I can't say, I think it's very interesting because if there is something with local prostate inflammation, and then if you really knock out or mitigate this TNF story, you're not using it for prostate cancer prevention, but it seemed to be within the cohort that there was a reduced risk of prostate cancer diagnosis. Now, these patients are always seen more frequently. So if you have mild disease, you're probably not being seen as someone who has severe disease, who's getting more office-based visits with their rheumatologist, their GI doctor, and whatnot. So, it certainly could be ascertainment bias or bias that they're in the system more, but the patients who are getting the TNF agents actually seem to be more engaged in the healthcare system, but they're being diagnosed with prostate cancer less. So I think it's a really interesting mechanism that I think is worthwhile studying because TNF plays a role in both, obviously, development and progression. So I think that'll be interesting to study, but I hope to tease that out in the future here.
Thank you.
Yeah, Shom, awesome work, total tour de force. How do you think about next steps of translating some of the mouse observations into humans? Meaning, are you prospectively banking tissue from these individuals? And if so, can you tell us more about that so we can participate? Or, what are your next steps in terms of translating that?
Yeah, I think that is the next step. We're trying to get more tissue, and I have, working with Jennifer, she has some tissue from IBD patients in her lab. I think she got some from Dan Lin, 16 years ago that are sitting in her lab that she's going to help kind of tease out, what's happening with the tumor microenvironment in these men with inflammation and prostate cancer. That data, I think, will be annotated, so it's not a large sample, but she may have about 50 patients that hopefully she'll be able to tease out. I do have to start a more prospective banking program, and specifically with the Digestive Health Foundation, or GI, because I want to not only know what's going on with prostate tissue, but the colon tissue as well. So yes, I think your point is a really good one. I need to start banking. I have plenty of tissue. I have a reasonable amount of tissue that have been previously paraffin embedded, and I have some of that tissue from both here and UFC, where we're doing some of the microbiome-based work, trying to figure out what bacteria are there. But yeah, you're absolutely right. It's a little bit of an ordeal, but something that I do have to chase down prospectively and figure out the right way and how to get colon tissue, because they take biopsies randomly in a lot of these colon tissue patients, but not everybody gets a biopsy. With transperineal biopsies, I know there's a lot of hesitation, for example, Steve Heinauer, to really getting any kind of prostate tissue in inflamed tissue in inflamed patients. But with transperineal, since we're actually not piercing the rectum, there may be an opportunity to get some prostate tissue when patients are having flares and things like that. So yes, absolutely, that will be a part of the next step. I think a lot of it is just trying to understand the tumor microenvironment and what's happening. This is beyond the scope of what I know, but luckily we have people who can help with that going forward. So you're right, that's something that I will need to start.
Yeah, I think the transperineal biopsy approach would be really nice for that, right? Because you can have a clean field, so to speak.
Exactly. And I think there was hesitation before, this was 2-3 years ago, but with transperineal, really without violating, the rectal mucosa, I think becomes a potentially different game. And these patients are sedated. So, we'll have to go through the IRB process, but it would be nice to get prostate tissue in some of these patients with IBD and then localize based upon what's happening with the different diseases. So UC and Crohn's are very different. So I think it'd be really interesting to see if somebody with Crohn's and an ileal flare is having upregulated, what's happening in the prostate in those patients versus somebody with rectal ulcerative colitis. So, yeah, I think I think it'll change the game as relates to being able to get tissue and not disturbing the local inflammation of the gut. All right, thank you, everyone. Any other questions? Well, thanks everyone for listening. I really appreciate the opportunity to talk. Thanks, Ashley, for inviting me, and look forward to working with all of you soon.
Thank you, Sean.
Really great.
Thanks, Sean. Thanks, Sean.